Hello, everybody. So while Dr. Huff makes his way over from the other room, I figured we could just do a quick little stretch. Let's get a little stretch break going here.
Okay, let's take our arms up nice and tall, get a good stretch, and release it down. Bend in your knee, yay. Reach up and breathe, and drop it down. Try that a couple times. Release any tension you have in your body.
Let's get a little stretch going on, Dan.
Last time.
Awesome.
Hold and exhale. Let's do a little ear to shoulder drop. And other side. Try that a couple of times. Get your neck nice and loose.
All right.
Hold over to one side. Take that hand and hold.
Pull the neck over.
Drop it through the
Don't
middle.
pull too hard.
And over to the other side. Grab that head.
Good stuff. All right, my man. Good to see you.
It was funny. My wife had this computer, so I thought I'll use this computer, and it kicked me out to reset the Google Chrome there. So I was all ready, and now I'm ready again.
Okay,
So,
good deal. So I'd like to
Daniel
introduce.
Huff.
Yep, go ahead.
Sorry,
do your
what?
thing.
Yep. My name's Daniel Huff. I am a podiatrist up in northern Utah. I own the Foot and Ankle Center of Cache Valley. I've been practicing for 13 years. And I've been working with pressure data now for a couple of years with Sensor Medica. And it's been fantastic. I continue to learn more and more. I've thoroughly enjoyed everything that's been presented so far. So this case that I'm going to do is about the impact of pressure in time. It's a case study about a talonavicular fracture with presenting hallux limitus and sesamoiditis. This patient presented to my office, 17-year-old Division I college basketball prospect. He presented with pain located over the dorsal aspect of his talonavicular joint. No history of trauma, no edema, no bruising, but just chronic pain that had been going on for a couple of years. On evaluation, you look at the lateral x-ray there. I have a little pointer that points to the talonavicular joint of an irregularity at the proximal dorsal aspect of the navicular. Yeah.
Your screen's not showing. You're not sharing your screen.
Okay. Sorry. Let me go back in here.
No problem. That's good. It's all good. Got to go down on where we are, and then share screen.
Share the screen. There we go. Okay. Coming back.
Good deal. There we go.
Yep. Thank you.
Yep. Pull the PowerPoint up. Perfect.
Awesome. Okay. There we go. There's that. Appreciate the heads up.
I don't see it yet.
Okay. Let me try again. And we will go to this one and try this. And try that. Did that work?
Perfect.
Okay, awesome. Right. Sorry for that. That was just me switching up computers was all that was. So thank you for the heads up. Going back here. So patient history. Here is this x-ray. Everyone can see that, right? Okay. So this 17-year-old Division I college basketball prospect. And you can see there on the dorsal proximal aspect of the navicular at the talonavicular joint, there's just a little bit of an irregularity. And then also the navicular cuneiform joint, there's a little bit of a collapsing that's occurring there. And when you evaluate the whole medial column, you looked at the range of motion of his first metatarsal phalangeal joint, and he's really only got about 10 degrees of dorsiflexion, just this really tight joint. And it's the same on both sides. However, this left foot, he was the one that presented with the pain of the talonavicular joint. He did have some pain plantar to the tibial sesamoid or the medial sesamoid. So he's a size 17 foot. He's 6'8". He's still growing. His growth plates are open. He is an NBA prospect. So he's got a great future ahead of him, provided he doesn't ruin his feet. And the feet are so important, right? So looking at the initial treatments, On that first visit, I just looked at that x-ray. I don't like to go straight towards surgery on something like this. I mean, it's just a career-ending surgery right off the bat. But when you look at an x-ray like that, the assumption is, well, maybe we've got a little broken fragment in there, and why is it? This is a common location for an extra bone to develop. And so that was kind of set aside, but I brought that up with the patient and his parents. I said, let's look at a CT. Let's see if this is indeed a fracture or if this is just a little extra piece of bone at the joint. I had him take some anti-inflammatories. We tried some strapping, taping, icing, and then some over-the-counter orthotics. I modified the medial column and tried to offload that first metatarsal and offload the sesamoid. With varying results, right? Not a lot of improvement. He continued to have pain. Here's his CT scan. The radiologist read this a little bit down. I have it underlined as a small os supranavicular anterior to the proximal navicular bone. Those are the three different planes. As you see there, I've tried to get the pointer close to where the comment is being made that this is just a traditional extra bone that's developed in this joint. I look at it and I wasn't in agreement. I felt like this was possibly trauma related, but it's really hard to get an image and then disagree with the radiologist and go to surgery. So we had him go get a second opinion at a really well-recognized facility that does a lot of sports medicine and works with Olympic athletes and college athletes and professional athletes. And their opinion was, this is possibly a stress fracture, so let's get an MRI. And on their MRI, we see a stress response of the navicular, but not necessarily any cracking of the bone or indication that the bone had been violated, just a stress response. So their recommendation was to take him to surgery and to do a subchondroplasty, take some bone cement, inject it into the navicular, and then cast him. They came back to me, let's go to this imaging first. And on the imaging, I've tried to point out the areas. There's the T1 and T2 weighted images to the right with a marker at the top of the screen there. And what you'll see is some edema within the navicular, but really just some disorganization at the exact same location as my x-ray shows this little piece of bone. And the density of it is different. It just is not carrying a signal on one image, and it is carrying a signal on the other. That would indicate pretty significant edema and inflammation at the site. The impression of this radiologist was that there was focal marrow edema at the dorsal medial aspect of the navicular bone. I don't know if he had a good x-ray to compare this with, but I can see that same fragment. It does look separate, and it has a changed density. So they came back to me to just discuss where we go from here. It's not good medicine to go against such a well-recognized facility and to take it straight to surgery. So I said, let's hold off. Let's go after this. But I don't think we inject the navicular with bone cement. We can really overdo this. So we put a bone stimulator on it, immobilized him, got him off of it, and tried to heal this stress response. And after a few weeks, he came back discouraged that there was no improvement, and I asked him if they would be okay if I took it to surgery and removed the fragment of bone. They were okay with that decision, so we moved forward. I did an arthrotomy of the talonavicular joint and excised a fragment that was fractured. You could see the violation of the cartilaginous surface on the dorsal surface. And so when I opened it up, there was a lot of thickened tissue around the surgical site, consistent with the fracture to the site. Again, he doesn't remember any history of trauma. He just remembers the pain coming on, and the fragment's quite small. So I've got a little video here that shows the procedure where I opened it up, and then this is me just pointing to this fragment and trying to show that at the space it is indeed loose and kind of moving around down inside there. And I think right there you can see pretty well the fragment, how it's loose and dislodged. So I removed the fragment, and then the cartilage edges were not healthy. So I actually smoothed the edges to good, healthy cartilage where it was intact. You'll see on the intraoperative photo to the left there, the fragment is gone. And then here's two images to the right. The top right-hand corner, you can see healthy cartilage of the talus. I can't get the other side with the image. It's hard to get a good picture of that, but that's smoothed down all around the joint. The bottom image was another attempt to just show you the fragment. So here's the fragment. Very, very small piece of bone that was really impacting this patient's foot. And so post-operatively, we look at, well, what happens? Immediate relief. The next day, he said, there's no more grinding in the joint. He'd never described grinding, but once it was gone, he was able to say, just don't feel it inside my joint anymore. The pain is gone. He didn't need any pain medication. It was immediate. So once his swelling went down after surgery, sutures healed up, we got him back into his shoe and introduced his activities and started working out. And what started? We started back into some sesamoiditis. The hallux limitus obviously was still present, but the sesamoid was hurting, just we're not getting range of motion. So we referred him out to physical therapy to work with the range of motion of the joint. And this is kind of when I started working with pressure versus time and with Sensor Medica and looking into it. I wanted to make him some orthotics with the way I traditionally would do neutral suspension casting and capture the foot and build a device that I felt like could offload the first metatarsal. But instead, I took this down the direction of using my pressure testing and looked at what was going on. Sadly, I have two sets of images from him, pre-op and post-op, and I can't find the pre-op pressure and time data. But you'll see how his first metatarsal and his forefoot, even after the correction and his physical therapy and being months in an orthotic, the first metatarsal really it's down immediately with the heel. The whole forefoot is, and there's increased weight on the forefoot. But as I go to this next slide, this was one image from before surgery. You can see how the line comes through his foot, but a lot of weight stays medially. And what I did is I marked out a subtalar joint axis. I marked out how we would decompress his first metatarsal phalangeal joint to avoid the supinatus, and built him an orthotic. So here is just a video of him after he's been in the orthotic for quite a while. You still see immediately loading of the forefoot. I think we're seeing, pressure versus time. You're seeing elongation of the arch. You're seeing high stress along the medial column. And I believe this is jamming his first metatarsal phalangeal joint. I think it's also overwhelming and overloading his talonavicular joint. And so using the 2D and the 3D and pressure analysis, I was able to place his corrections on his orthotic design correctly, invert his heel, put a Kirby heel skive. I dropped his first metatarsal at the hallux limitus axis point. I dorsiflexed his hallux a little bit and then put some of the pressure over into his lateral forefoot by offloading those metatarsal heads. This additionally offloaded the first metatarsal head, and what we got was complete resolution of his talonavicular pain, increased range of motion. Last physical therapy assessment was 50 degrees of dorsiflexion of the joint. Sesamoiditis is completely resolved, and future college basketball career intact with a potential opportunity with the NBA down the road. That's provided he doesn't choose to be a podiatrist, because he's so fascinated by what he's gone through here. He's told his parents he would love to be a podiatrist. So I love what I'm doing with this. I'm learning more and more all the time with it. I think it's fantastic for biomechanics to be able to just get this much data to treat what we're doing. And I think this is a good example of how we can take something that doesn't make sense and make perfect sense of it. So thank you.
Awesome. Just hit stop sharing. Good. Perfect. Great presentation. We don't talk enough about biomechanics post-surgery, right? We talk about pre-surgery, or actually not even surgery in biomechanics, but you need to understand biomechanics when doing surgery. So that was a great case study. Absolutely. Yeah. So we're going to move on. The next session is going to be a little bit of trivia, a little fun time, whatever. We're going to be the winner of the trivia will get a $100 Amazon gift card, courtesy of Sensormatica. So that's pretty cool. And we have a little bit of fun with that. So give everybody a little bit of break, and then we'll come back with the round table right after that. Okay. Awesome. Thanks, Dr. Huff.